Welcome. My name is Joe Swanson. I'm Associate Professor at the University of Tennessee Health Science Center in the College of Pharmacy, and I'm going to be presenting the pharmacokinetics and pharmacodynamics section of the 2016 Critical Care Preparatory Review and Recertification course. First, I'd like to start with I have no conflicts of interest to disclose. Second, you'll see listed here are my learning objectives. The learning objectives for this seminar are to describe the changes in critically ill patients that alter drug absorption, explain how critical illness affects the distribution of drugs, depict the effects of changing hepatic blood flow, intrinsic activity, and protein binding on drug metabolism. I'd like to cover differentiation between critically ill patient populations and expected pharmacokinetic changes, incorporate the pharmacokinetic changes in critically ill patient into the design and evaluation of appropriate drug regimen, and identify the desired pharmacodynamic parameters associated with efficacy of select drugs. Our agenda for today will be to cover changes that can occur in our critically ill populations with regard to absorption, the volume of distribution of drugs, metabolism, excretion. We'll spend some time on the pharmacodynamics of drugs and specific drug categories. And then also we'll briefly touch on therapeutic drug monitoring. Unfortunately, there are no key guidelines for the pharmacokinetic changes in the critically ill patients, nor are there key guidelines for pharmacodynamic changes in critically ill patients. And as I go through the presentation today, you will see that we essentially use small studies, case series, or case reports to help to support our decision making in this area regarding the changes that we see occurring in critically ill patients. So for our agenda, we'll begin with absorption. This slide depicts the bioavailability of various routes of administration of medications. And we're all familiar with the fact that if we give a drug intravenously, the bioavailability is 100% or F is equal to 1. Unfortunately, especially in our critically ill population, bioavailability of various other routes is less than 1 or highly variable but less than 100%. Routes such as subcutaneous, intramuscular, transdermal, oral, or patients who are mechanically ventilated, enteral, or inhaled all suffer from issues related to bioavailability. And some important factors that we need to consider are the incomplete absorption that we might expect to see from these various routes, and then from the oral or enteral route, the first pass effect on hepatic metabolism that may happen on certain drugs. And when we get into the discussion of metabolism, specifically highly protein-bound, hepatically metabolized drugs, you'll see that we'll even have variation there occurring that would also affect the bioavailability of drugs in our critically ill population. We'll start off with patient case number 1. So JN is a 40-year-old male receiving treatment for community-acquired pneumonia. Medications on admission to the hospital include ceftriaxone 1 gram intravenously every 24 hours, half normal saline as fluids at 50 mils per hour. On day 5, JM develops a fever, increased leukocytosis, tachypnea, and experiences an episode of hypotension unresponsive to 2 liters of normal saline. His past medical history is significant for hyperlipidemia. He is 5 feet 10 inches tall and he weighs 85 kilos. You can see here the laboratory values for the patient. The sodium is normal, his potassium is slightly low. Other things that would be important to note are his BUN and creatinine are normal. He has a slightly elevated blood glucose. He has a low magnesium. His phosphorus is low, and his albumin is somewhat declined. He has an elevated white blood cell count, as we previously described, and you can see the rest of his CBC values there. His heart rate is 120 beats per minute, so he's tachycardic. Respiratory rate 24 breaths per minute, and he has an elevated temperature. And his mean arterial pressure is 59 millimeters of mercury. The team has inserted a pulmonary artery catheter in this patient, and the values are as indicated below. Cardiac index of 4 liters, central venous pressure of 7 millimeters of mercury. His pulmonary artery wedge pressure is 15 millimeters of mercury, and the systemic vascular resistance is 700 times seconds per centimeters. On the admission orders, the physician resident orders the following vent settings you can see there. He has intermittent pneumatic compression devices to the lower extremities bilaterally. He's going to perform a bronchoscopy due to the patient's deterioration, and he's expanded the antibiotic coverage to imipenem cilastatin 500 milligrams intravenously every 6 hours, tobramycin 350 milligrams intravenously every 24 hours, vancomycin 1 gram intravenously every 12 hours. You can see some other standard medications that we would see in an ICU patient. He has stress ulcer prophylaxis with esomeprazole 40 milligrams per tube every 24 hours, heparin 5,000 units sub-Q 12 hours. He's on vasopressor norepinephrine at 10 micrograms per minute and titrating to the mean arterial pressure of greater than 65 millimeters of mercury. They are giving a normal saline bolus now, 1 liter, and then they've increased his normal saline rate. They've changed him from half normal to normal saline, and it's at 200 milliliters per hour. Morphine, 2 milligrams intravenously every 4 hours, scheduled, and then morphine, 1 milligram intravenously every 6 hours, PRN for pain. And he also has a propofol that's titrated to a SAS of 3 to 4. So I'll give you a moment to take this in. Which of the following medications presents the greatest pharmacokinetic problem related to absorption? If I were presenting this live, I would look for hands to be signaled to tell me which one of the potential answers here that the audience would have selected. So I'll give you a little bit more time to think about it. All right, so our options are heparin, 5,000 units subcutaneous Q12 hours, albuterol, inhalation or nebulizer every 4 hours, morphine intravenously every 4 hours, and esomeprazole per tube every 24 hours. So if you selected heparin subcutaneously, that is definitely a correct answer. And if you also selected esomeprazole per tube, that is also a correct answer. So both of these bypass the route of intravenous. We are giving them enterally or we're giving them subcutaneously. So we will definitely have potential issues for absorption. And obviously, critically ill patients change significantly over time. And so what may not be appropriate now in a patient in what appears to be septic shock may be appropriately a few days from now after that's resolved and we have better distribution of blood flow. Speaking of which, things that can alter absorption in the critically ill patient, the first thing I've listed here for you is perfusion. Obviously, in shock states, we have shunting of blood, shunting towards the vital organs, away from other organs. We also know that these patients, like the patient in the example, are receiving vasoactive drugs. Unfortunately, the literature reports variable effects of these. So some studies have demonstrated that vasoactive drugs actually will decrease perfusion of splanchnic organs. Others have shown some increased perfusion. And so we have a variable effect, or basically an unknown effect in our patients who are critically ill. Additionally, decrease in perfusion has the potential for affecting cell wall enzymes and causing dysfunction there. And so any drug that's absorbed via an enzyme in gastrointestinal tract has the potential for decreased absorption. Additionally, we see here that intestinal atrophy occurs in critically ill patients who are fasting for approximately 3 to 5 days. And so as we know, this breakdown in the intestinal tract can put patients at greater risk for developing infections. However, there's an unclear effect on drug absorption. This just hasn't been studied systematically to determine exactly what effect it would have on the absorption of medications that were administered enterally or orally to patients. However, it does warrant concern on our part for alterations in absorption of certain drugs. Additionally, you can see here that we have intestinal dysmotility occurring as high as 60% of the time in patients that are critically ill. And so we all know the patient that has elevated residuals or has some form of intestinal dysmotility. And obviously, we're going to be concerned then about the absorption of enterally administered drugs in these patients. In patients who are tolerating enteral nutrition, we do have the issue of physical incompatibilities, and I'll provide some specific examples for you as we go through the lecture. And additionally, pH changes can alter absorption of drugs, specifically proton pump inhibitors and/or H2 antagonists that we commonly use for stress ulcer prophylaxis in this patient population. So what types of things predispose a patient to delayed gastric emptying? You can see here a list of either patient states or treatments that can contribute to delayed gastric emptying. And if you look at these, you'll find that the majority of critically ill patients will either experience or receive one of these reasons throughout their stay in the ICU. My current clinical practice is in a trauma intensive care unit, and so we have all sorts of reasons to see delayed gastric emptying in our patients: trauma, traumatic brain injury, postoperative ileus, mechanical ventilation, certainly surgery, shock states. All of those are common in our trauma ICU patients, but I would venture to guess that the majority of ICU patients receive opioid analgesics. Oftentimes, patients are admitted for sepsis or septic shock, and a good deal of the patients in the ICU will be receiving mechanical ventilation, and all, if not nearly all, patients experience some degree of electrolyte abnormalities. And so as a result, all of the patients that we see, or the majority of the patients that we see, vast majority, are at risk of delayed gastric emptying, and therefore we are concerned about administration of medications via the enteral or oral route. Physical incompatibilities, as we talked about previously, enteral nutrition, also commonly referred to as tube feedings. We know that there have been documented examples, and they're listed here for you, phenytoin being one of those top on the list. We've noted decreased serum concentrations of phenytoin. And the approach that we've generally taken if a patient has to have phenytoin administered enterally is to hold the tube feedings for 2 hours around the dosing. That's if we are going to continue administering it via the enteral route. Generally, what we'll do to ensure that there's appropriate bioavailability of phenytoin is administer it intravenously. Warfarin has had in vivo and in vitro testing done. In vivo, we've seen decreased PT-INR in patients who were on warfarin therapy and had enteral nutrition administered at the same time as the warfarin. And then in vitro, we've seen where warfarin therapy has been, or warfarin has been administered along with tube feeds into a container, and that container was filtered, in which we found that warfarin was binding to products in the tube feeds. So therefore, clinicians will take varying approaches to this, depending on how likely the nursing staff is to hold the enteral nutrition around the warfarin dosing. You can do that. Recommendations can be for 1 hour pre and post dosing, up to 2 hours pre and post dosing. Some clinicians have noted to treat through the interaction, and so you'll see a patient who is receiving a much larger dose of warfarin than what they had previously required in order to overcome that binding in the tube feedings. Excuse me. Fluoroquinolones have been noted in several studies to have interactions with enteral nutrition. We've noted that the concentrations of fluoroquinolones administered concurrently with enteral nutrition have been decreased. However, how to deal with this the recommendations have been conflicting. So what we found is that some recommendations state that you should hold the enteral nutrition around the fluoroquinolones. Other data have demonstrated the decrease in AUC was not significant enough to affect the pharmacodynamic parameter of AUC to MIC and the efficacy of those fluoroquinolones. And so oftentimes you'll see recommendations of administering them concurrently despite this noted interaction with the enteral nutrition. And then finally, levothyroxine has been noted to interact with enteral nutrition. And Dickerson and colleagues found an overt subclinical hypothyroidism in patients who were administered their levothyroxine enterally along with enteral nutrition. And we found approximately 60% of patients develop this. And so recommendations vary on this also, whether or not to treat through it with a larger dose, whether or not to utilize an intravenous dose, or whether or not to hold the enteral nutrition around this. This next slide depicts examples from non-critically ill patients, but it highlights an important concept that as we increase the gastric pH with the administration of either an H2 antagonist or a proton pump inhibitor, we run the risk of altering enteral absorption of medications. And as you can see here in the second column, some medications, the enteral absorption is increased as we increase the gastric pH. Drugs like nifedipine, digoxin, alendronate can all have increased absorption and possibly increased effects in patients who are receiving these H2 antagonist or proton pump inhibitors. Also, we see a decreased enteral absorption in other medications like itraconazole, cefpodoxime. You can note that these were non-critically ill patients, but the increase in gastric pH would be expected to be similar in our critically ill patients. And so we might be able to extrapolate these data and consider the effects that they might have in a critically ill patient or administering one of these medications enterally concomitantly with a proton pump inhibitor or H2 antagonist for stress ulcer prophylaxis. Also, I think this slide is very important to highlight that we have information on basically 8 medications and the effects that pH has on the absorption of these drugs. And so it's really unclear in our ICU population about what type of effect the pH of the gastric contents has on the absorption of other enterally administered medications. And I'll just summarize that section for absorption based on the way that we approach it clinically, and that is we try to avoid the route of enteral or oral or subcutaneous routes when at all possible in our patients who are in the ICU. As we mentioned, though, these patients, their condition will change oftentimes rapidly, but as they progress and improve and are ready to be transferred out of the ICU, we can begin to initiate these other medications. We can take routes such as subcutaneous or enteral as potential routes to be utilized for our ICU patients once they become to stabilize. And oftentimes what you'll find is that clinicians use the tolerance of enteral nutrition as a surrogate marker for absorption of medications. And that's important to approach logically, but however, we don't know what effects those patients have, what effects that status of their tolerance of enteral nutrition has on absorption. So let's move now into the volume of distribution of alterations in critically ill patients, and we'll come back to our first patient case. I won't rehash, but it's basically the same person, JN, the 40-year-old male with community-acquired pneumonia, who then is admitted to the ICU with septic shock. And now, based on the likely changes in the volume of distribution, which would be the best extended interval dose of tobramycin? Should it be 400 milligrams intravenously every 24 hours, 750 milligrams intravenously every 24 hours, 250 milligrams intravenously every 24 hours, or 600 milligrams intravenously every 24 hours? And I'll give you just a moment to consider your answer. So if you picked 600 milligrams intravenously every 24 hours, I'm going to agree with you on that. Some people may have picked 400 milligrams intravenously 24 hours because that does include the dose that would be within the normal dosing range of an aminoglycoside, specifically tobramycin, and once daily or extended interval dosing. But let's just take into consideration our patient's specific factors and what we might expect. The patient is 5 feet 10 inches, he's 85 kilos, he has good kidney function. We know that the standard dose for tobramycin is 4 to 7 milligrams per kilo per dose. And I would actually recommend picking the higher end due to the likelihood for an increased volume of distribution in this patient. And so I say here that his weight being 85 kilos times 7 mg per kg gives us 595 milligrams. And the closest dose in range is 600 milligrams intravenously every 24 hours. So most of you are familiar with the equation for volume of distribution. The volume of distribution there on the right is equal to the dose over the initial concentration. Clinically, we generally use this equation for loading doses, and we think about it in terms of the initial concentration that we want to achieve is equal to the dose of the drug over the volume of distribution of that drug in the patient. And again, in the critically ill population, we're going to see alterations in the volume of distribution. And so tissue perfusion is one of these factors that can alter our volume of distribution. Again, in shock states, we have a redistribution of blood flow. We generally see a decreased perfusion of muscle, skin, splanchnic organs. So this has the potential to reduce the volume of distribution of hydrophilic drugs. So we found in certain studies that lower gentamicin concentrations were found in the microcirculation. And so this is at the site of the infection, we see a lower volume of distribution and decreased concentrations at that capillary level in that microcirculation. So that is one effect that we might expect to see. We can see that antibiotics, the volumes of distribution, we might expect to be able to separate them into the hydrophilic agents and the lipophilic agents. And we know that the hydrophilic agents generally have a smaller volume of distribution, things like the beta-lactams, aminoglycosides, or glycopeptides. The lipophilic agents generally have a larger volume of distribution. We see things like fluoroquinolones, macrolides, oxolidine-diones, and the tetracyclines. All of those may be less affected by changes in our critically ill patients because of this large volume of distribution. Now, the first slide in this section for volume of distribution noted that we may see decreases in volume of distribution of drugs like gentamicin because of shunting. Something else to take into consideration, especially based on my answer to the patient case, is that we see fluid shifts that can alter our volume of distribution. And I've just used the early goal-directed therapy study from Rivers to note for you the amount of fluid that's received, even if we are administering early goal-directed therapy, very targeted, and being very cognizant of the amount of fluids that we give. And as you can see here, at 72 hours, those patients have received an average of 8 liters of fluid plus or minus 5 liters of fluid. And so with this large volume resuscitation in crystalloids, we have the potential to administer the same volume as our extracellular fluid, which would mean that these fluid shifts can occur. That intravenous fluid, these crystalloids that we administer, has to go somewhere. And so we would essentially be increasing our total body water by increasing fluid in the intravascular and interstitial spaces. Also, comorbidities such as sepsis, burns, acute respiratory distress syndrome, acute kidney injury, all of those can cause fluid shifts that would alter the volume of distribution of drugs that have a small volume of distribution, like those antibiotics we talked about. Additionally, past medical history, patients with heart failure, patients with cirrhosis, or patients with chronic kidney disease may also already have fluid shifts, and they may be more susceptible to fluid shifts from fluid resuscitation and other comorbidities. And ultimately, patients who have surgery can also have changes. And generally what we see is that the changes listed above result in an increase in total body water and an increase in that interstitial fluid. This then would increase the volume of distribution of drugs that already have a small volume of distribution, like our beta-lactams, like our aminoglycosides, like drugs like vancomycin. That is why in my initial patient case, I recommended that we would use a larger dose. pH changes can alter the volume of distribution. So acid-base disorders are common in critically ill patients. Most drugs are weak acids or weak bases. We also know that changes in pH can alter the degree of ionization of a drug, and the changing in the ionization of a drug will alter the membrane permeability, either increasing or decreasing the membrane permeability based on what degree of ionization we see in those medications. And so this can alter where these drugs will distribute. It's important to take into consideration conditions in our ICU population that may cause changes in pH. When we look at the two columns on the left side here, we see states of acidosis, either respiratory or metabolic, with conditions such as asthma, neuromuscular disease, obstructive sleep apnea, depression of our central nervous system, or chronic obstructive pulmonary disorder. We can see metabolic effects like renal failure, diabetic ketoacidosis, or renal tubular acidosis, lactic acidosis, medications, or diarrhea, all causing pH changes that could be clinically significant and affect the distribution of drugs in the body. The right two columns demonstrate respiratory and metabolic alkalosis. As you can imagine, anything that would cause the patient to breathe more rapidly would produce a respiratory alkalosis like pain, anxiety, pneumonia, pneumothorax. And so you can see that these conditions may produce pH changes that would alter our volume of distribution of critically medications in our critically ill population, as well as metabolic effects like nausea, vomiting, diuretics. All of these things are commonly seen in our ICU patient population, and so we can see alterations in the volume of distribution of drugs based on changes in our pH. Finally, protein binding changes can alter the volume of distribution. You can see that via the equation here on the right. Important proteins that we have to take into consideration are alpha-1 acid glycoprotein, or AAG. This generally binds basic drugs, and albumin, this generally binds acidic drugs. But we also have to worry about lipoproteins and cortisol binding proteins. Now, in critical illness, albumin concentrations have been characterized to be decreased, whereas alpha-1 acid glycoprotein, or AAG, concentration have been noted to be increased in states of critical illness, specifically shock or high stress. And so as we think about drugs that are bound to albumin, we can see a list of drugs here. I've given you a table that shows drugs with certain extraction ratios, high, intermediate, or low extraction ratio drugs. But all of these drugs are bound to albumin, and so we can expect that their volume of distribution can be affected by changes in this protein. Also, alpha-1 acid glycoprotein, you can see the medications listed here, high, intermediate, and low E drugs that would commonly be used in the ICU and are bound to alpha-1 acid glycoprotein. And so we can see changes occurring in these drugs. Unfortunately, we don't have very specific studies that will explain to us the exact effect on the volume of distribution of all of these medications, especially when you take into consideration the fluid status, the shock state status, the pH of the patient's blood, and the protein binding of specific drugs. And so what we'll oftentimes find ourselves doing is looking at pharmacodynamic responses, which we'll talk about a little bit later on in the lecture. So we've talked about absorption, we've talked about volume of distribution. Let's now step into metabolism. We'll start with patient case number 2. JM is a 65-year-old female who in the ICU who develops atrial fibrillation. Her rate is controlled using a diltiazem infusion of 10 milligrams per hour. She develops a fever, leukocytosis, and is empirically initiated on vancomycin, piperacillin, tazobactam, and fluconazole. You can see the dosing for each of these. So question number 3 is, which pharmacodynamic response would you most expect to see in JM? Would you expect to see an increased heart rate caused by an increased intrinsic clearance of diltiazem? Would you expect to see a decreased heart rate caused by a decreased intrinsic clearance of diltiazem? Would you possibly see an increased heart rate caused by a decreased unbound fraction of diltiazem? Or would you see a decreased heart rate caused by an increased unbound fraction of diltiazem? I'll give you a minute just to think about that. So the correct answer is we expect to see a decreased heart rate caused by a decreased intrinsic clearance of diltiazem. And let's get into the metabolism, and then you'll begin to figure out why that answer is correct. So there's some important pharmacokinetic definitions that we need to be aware of. First off, metabolism is the biochemical modification of a pharmaceutical substance, specifically a drug. Excretion is the removal of a pharmaceutical substance or drug from the body. You'll oftentimes hear the term clearance or elimination, which the definition for these are the removal of a pharmaceutical substance, drug, from a volume of plasma over a given time. So you'll see clearance and elimination oftentimes being used when we're referring to metabolism of a drug, or also when we're referring to excretion of a drug. Many people don't realize that the kidney plays an important role in metabolizing many drugs. And in fact, cytochrome P450 activity has been noted in the kidneys, specifically with isoenzymes 2B6, 2C8, 2C9, 3A4, and 3A5. And so most of you are familiar with drug interactions that occur via the cytochrome P450 enzyme pathways. And as you can see here, some of these are very important when it comes to commonly used medications. And so changes in renal metabolism can be significant in terms of disposition of a drug in the body. It's just been recently that we've been categorizing the kidney's ability to metabolize drugs via the cytochrome P450 activity. And so we don't have as much data as we would like in this area to characterize what types of effects we see. But it is important to note that we do see renal metabolism of drugs that can alter the effect of these medications in our body. Also, we can see our UGT isoenzymes 1A9 and 2B7 are in the kidney, and they can be affected. I like to tell the example, we have changes in our insulin infusion protocol based on patients who are in renal failure. And part of the reason, obviously, is that the kidneys eliminate or excrete insulin as one of their major roles, but they also serve a role in metabolizing insulin. And so as a result, we see that we will implement a different protocol for insulin infusion in our ICU patients that have developed acute kidney insufficiency. Everybody's more familiar with hepatic metabolism, specifically hepatic metabolism of highly protein-bound, hepatically metabolized drugs. And we are all familiar with the categorization of high extraction ratio drugs and low extraction ratio drugs. And so if we were to mathematically describe hepatic drug clearance, we would note that the clearance of a drug via the liver is equal to the liver blood flow times the extraction ratio. Excuse me. And so QH being hepatic blood flow, E being our extraction ratio. We also know that the extraction ratio can be characterized by the following equation, which is the fraction of unbound drug times the intrinsic clearance divided by the hepatic blood flow plus the fraction of unbound drug times the intrinsic clearance. And this will be important as we think about high E and low E drugs and the effects that extraction ratio has on hepatic metabolism or clearance of drugs. Again, let me just make sure that everything is clear in terms of our variables. QH, whenever we refer to QH, this will be the term that we'll be using for total hepatic blood flow. F sub U will be the fraction of unbound drug, oftentimes referred to as the free drug or the drug that's able to interact with the tissues. And so this is what's going to be really important when we think about the effect that we might see with changes in metabolism of these drugs. The intrinsic clearance, or CL sub INT, is the ability of liver enzymes to remove or clear drug. And so remove or clear drug can be one of two ways. It can either be metabolized or it can be excreted in the bile. So what types of changes in QH or hepatic blood flow do we see in our critically ill patients? Well, as you're probably beginning to realize, we see changes in our patients on a very rapid basis in the ICU. So as a result, we would expect to see that we would have increases in hepatic blood flow and decreases in hepatic blood flow that might be associated with various different states. So in the hyperdynamic phase of sepsis, we would expect to see an increased cardiac output. That increase in cardiac output should correlate with an increased blood flow. Also, the administration of inotropes should cause an increase in cardiac output, therefore increasing hepatic blood flow. We can think about states that would decrease blood flow, like late sepsis, shock, specifically hypovolemic or hemorrhagic shock, myocardial infarction, where we've lost part of the myocardium and decreasing our cardiac output, heart failure exacerbation via the similar mechanism. Mechanical ventilation has been noted to increase or decrease cardiac output, specifically in situations where the patient is receiving an increased positive end expiratory pressure. This increase in that pressure increases the pressure in the intrathoracic cavity. That then compresses the myocardium and therefore reduces the heart's ability to pump blood, and we see a resultant decrease in cardiac output. And then vasoactive drugs, specifically drugs like vasopressin, may be such great vasoconstrictors that we see decreased blood flow to the liver. It's important for me to note that there are no studies confirming that vasoactive drugs like vasopressin decrease hepatic blood flow, but the concept is sound in that we would expect to see decreased perfusion to tissues from potent vasoconstrictors like vasopressin. And so we might expect that we would see a decrease in our hepatic blood flow. Again, as we saw with volume of distribution, plasma protein binding changes can affect the metabolism of highly protein-bound, hepatically metabolized drugs. And as I stated before, alpha-1 acid glycoprotein, AAG, is increased in conditions like trauma, stress. Albumin has been noted to be decreased in multiple conditions like trauma and stress that we would expect to see in our ICU population, and then also in malnutrition in some patients. Not necessarily ICU specific, but can be ICU related. We know that the intrinsic clearance or the enzyme activity in the liver can be altered by things such as cytochrome P450 interaction. So if you are co-administering a cytochrome P450 inducer with a substrate, you would expect to see that the metabolism of that drug, the substrate, would be increased. And conversely, if you co-administer an inhibitor with the substrate, you would expect to see that metabolism of that drug would go down. And so drugs can affect this. Interestingly enough, it's been noted that critical illness, specifically critical illness that would stimulate the production of cytokines, has been noted to decrease cytochrome P450 activity. So as you find a patient that has a condition where you would expect to see increase in our inflammatory cytokines, you can expect to see decreases in our intrinsic clearance of those drugs that are metabolized via the CYP450 system. Traumatic brain injury, or TBI, has been noted to, those patients have been noted to have increased clearance of drugs like phenobarbital via the phase 1 oxidative metabolism, phenytoin, or even lorazepam via phase 2 glucuronidation. And so patients with traumatic brain injury, we're expecting to see decreased clearance of these drugs. With nutrition support, we've also found, and this was generally when we were using phenytoin for longer periods of time, upwards of a week, outside of a week. Most of the time, patients with traumatic brain injury are just receiving phenytoin for 7 days now. But in the rare cases where they require continued phenytoin therapy, Boucher et al. Noted that there was an increased clearance of phenytoin after that first week of therapy. And so patients who were previously therapeutic now have subtherapeutic concentrations that they found to be related to increased clearance of phenytoin. The only variable that was noted to be significantly associated with the patients who had decreased phenytoin concentrations was aggressive nutrition support. And when I say aggressive nutrition support, I mean that these patients were receiving larger than normal doses of protein. And so we might expect to see patients with 2 to 2.5 grams per kilo per day of protein in their nutrition. We might expect to see them have decreased phenytoin concentrations further out, at least based on this study from 1988. So let's talk about drugs and what effects we might expect to see in the ICU based on changes in variables that relate to their metabolism. We can first look at the high extraction ratio drugs. And you see here high E drugs, generally with the ratio of greater than 0.7. We noted before that the clearance of hepatic drugs, in high extraction ratio drugs, the clearance of these hepatic drugs is specifically equal to the liver blood flow. And so again, our high E or high extraction ratio drugs that are bound to albumin, drugs like propofol, morphine, propranolol, verapamil, or those that are bound to alpha-1 acid glycoprotein like lidocaine, fentanyl, propranolol, and verapamil. And these are mainly examples of drugs that we would expect to see used in critically ill patients. Again, this slide highlights the fact that there are very few drugs that have been identified in this area to be affected by changes that we might expect to see as it relates to their status as a high extraction ratio drug. So what types of changes could we see in our critically ill patients, and what types of consequences would we expect? Well, we can use these equations to figure out what would happen in our patients who are receiving a high extraction ratio, highly protein-bound drug that is hepatically metabolized, when we have changes in their various states that affect that. So we saw before clearance is equal to liver blood flow. The concentration steady state is equal to dose over clearance. And so as you can see here, concentration steady state is equal to dose over liver blood flow. If we want to find out what the concentration steady state of the unbound drug, or importantly, the active drug, or the drug that is free to interact with the tissues and cause its effect, we see here that the concentration steady state unbound is equal to the fraction unbound times the dose divided by liver blood flow. And so then when we think about what changes might affect specifically concentrations of our drug, we can look at the diagram to the right here and understand basic simple proportions. So as you have an increase in the hepatic blood flow, which is on the denominator of the equation, you would expect then that you would see a decrease or the inverse relationship, the inverse occurrence in the concentration steady state and concentration steady state unbound. So as liver blood flow goes up, we expect to see these highly protein bound, high E drugs that are hepatically metabolized, their concentrations to go down. The liver is being perfused by blood with the drug, it metabolizes those, it converts them, and therefore we see decreases in concentrations. Conversely, if we have a decrease in liver blood flow, something like a late sepsis state, where we're decreased cardiac output and decreasing in this liver blood flow, we might expect to see increases in our concentration steady state, and importantly, increases in our concentration steady state unbound. And so those conditions where we see decrease in liver blood flow, we may be concerned about supertherapeutic concentrations of medications that are high E, highly protein bound, hepatically metabolized drugs. Because intrinsic clearance has no effect whatsoever on the hepatic clearance of high extraction ratio drugs, we would then see that any change in intrinsic clearance is an increase or a decrease would have no effect on the concentration steady state, nor an effect on the concentration steady state unbound of high E, highly protein bound drugs. Now, the effect of the unbound fraction of drug is going to be different depending on whether you're looking at the concentration steady state or the concentration steady state unbound. And so as we see an increase in the fraction unbound, we would see no effect on the concentration steady state, but we would see a proportional effect on the concentration steady state unbound. So as we see an increase in our fraction unbound, we would see an increase in our concentration steady state unbound. As we saw a decrease in our fraction of unbound drug, we would see a decrease in our concentration steady state unbound. And so this is important to think about as protein binding changes occur. If we have changes in our protein binding that result in an increase in the unbound fraction unbound, we would expect to see changes in our steady state unbound concentration that were similar to that. Low extraction ratio drugs are categorized as an extraction ratio of less than 0.3. And for these drugs, the hepatic clearance is equal to the fraction of unbound drug times the intrinsic clearance. And so as you can see here, liver blood flow has no effect on the hepatic clearance of low extraction ratio drugs. So the hepatic clearance is independent of liver blood flow, but it is highly dependent upon the fraction unbound and the intrinsic clearance. Drugs that we would consider to be highly protein-bound, low extraction ratio drugs are listed here. The first row, obviously, is those that are bound to albumin. We can see the low extraction ratio drugs of carbamazepine, ceftriaxone, dexamethasone, diazepam, phenytoin, valproic acid, warfarin, diltiazem, and the alpha-1 acid glycoprotein. We see drugs like carbamazepine or diltiazem. And so this is important to be thinking about when we were talking about our example. We see the concentration steady state of a low E, highly protein-bound drug that is hepatically metabolized, depicted here. So the equation that we discussed before, the clearance is equal to the fraction unbound times the intrinsic clearance in the liver. So basically based on the enzymatic activity. The concentration steady state is going to be equal to the dose over the clearance. And as we just discussed, the clearance then would be equal to the fraction of unbound times the intrinsic clearance. We then multiply both sides by the fraction unbound to get the steady state unbound concentration. We see that the steady state unbound concentration is equal to the dose divided by the intrinsic clearance. And so the fraction unbound here, changes in fraction unbound would have no change on our concentration steady state unbound of specifically a low extraction ratio, highly protein bound, hepatically metabolized drug. So again, liver blood flow has no effect on the clearance of these drugs, and so therefore it would have no real effect, or changes in liver blood flow would have no real effect on the concentration steady state or the concentration steady state unbound. And so increases in QH would be no difference in CSS or CSSU, and the same thing with the decreases in QH, there would be no change in CSS or CSSU. If we have an increase in our intrinsic clearance, as we look over at the equations, logically we would have the inverse effect in our concentration steady state and our concentration steady state unbound. So as you gave, for example, a drug that was inducing the activity of P450s of a low E, highly protein bound drug that was metabolized by a cytochrome P450, you would then expect to see a decrease in that drug's concentration steady state. Also, you'd expect to see in the steady state unbound concentration a decrease. Conversely, if we have a decrease in our intrinsic clearance, we would expect to see an increase in our steady state concentration and our steady state unbound concentration. And so giving an inhibitor in this situation to inhibit the hepatic metabolism, that intrinsic enzyme activity, we would see increases in our concentrations of steady state and steady state unbound of low E, highly protein bound, hepatically metabolized drugs. Again, changes in the fraction unbound are going to be variable depending on which concentration you're looking for. So as we see an increase in the fraction of unbound drug, we would see the inverse happen to the concentration steady state. So as the fraction unbound goes up, we would see a decrease in the concentration steady state, but we would see no effect on the concentration steady state unbound. Conversely, a decrease in the unbound fraction of drug, the fraction of unbound drug, excuse me, we would expect to see an increase in our concentration steady state, but again, no change in our concentration steady state unbound. So now we see we've gone through absorption, we've discussed the volume of distribution, we've discussed the metabolism of drugs. Now let's discuss excretion and changes we might expect to see in our ICU population. We'll start off with another patient case. This is patient case number 3. CP is a 50-year-old man. He's admitted to the medical ICU for diabetic ketoacidosis. His medical history is significant for hypertension, type 1 diabetes, and a myocardial infarction 2 years ago. He quit smoking last year and only drinks alcohol occasionally. His vital signs are significant for tachycardia, heart rate of 125 beats per minute, a blood pressure of 95/65, and a respiratory rate of 22. His significant dehydration contributed to the development of AKI, and his current serum creatinine is 2.8. His blood glucose is significantly elevated at 350 milligrams per deciliter. He will be initiated on continuous intravenous infusion of insulin to correct his blood glucose. So which factor is most important to consider when dosing insulin in CP? So A, the decreased renal metabolism of insulin, B, the increased volume of distribution of insulin, C, increased hepatic metabolism of insulin, or D, decreased receptor binding of insulin. I'm pretty sure I gave you the answer to this earlier, but I'll give you just a moment to think about this. As we talked about before, insulin is metabolized in the kidney. It's also renally eliminated, and so this person would, or excuse me, renally excreted, and so this person here would also be at risk of accumulation of insulin. So where are drugs excreted? We generally think about drugs being excreted from the kidney for the most part. We think about drugs going through absorption, biotransformation via metabolism to a more hydrophilic substance. That more hydrophilic metabolite then is suitable to be eliminated or excreted by the kidneys. And so what we see here then is the majority of drugs and their metabolites are excreted by the kidney, either via filtration or tubular secretion. Tubular reabsorption can affect what happens to those drugs, but it's not part of the excretion process. It can augment the excretion of those drugs. Additionally, drugs can be excreted in the bile or feces. You can see here the specific molecular weight of drugs that we oftentimes see this occur with. We do see some enterohepatic recirculation, and there's generally fewer drugs that we would see that would be excreted in the bile or the feces. And I've given you just a few examples here. This is certainly not an exhaustive list of drugs that are excreted in the bile or feces, but it just highlights that there are some important medications that we'll use in our ICU population that will be excreted in the feces, and therefore we would need to take into consideration the removal of these drugs from the body via this route. The lungs also are responsible for excreting drugs, specifically ethanol and gaseous anesthetics. This is something that we generally don't delve into in our ICU population. We know that this occurs, but it's not as if we're using this clinically to make decisions about patient care, at least for the most part. So I use this slide to demonstrate from various studies that I've pulled together what types of renal drug clearance or excretion do we see in the ICU based on the type of ICU patient population you might expect to see. So as you can see here, the first column shows burn ICU patients, the second medical surgical ICU patients, the third is trauma ICU patients, and then kind of bunching these all together, all of the ICUs, what we might expect to see. Now this slide is compiled from multiple studies in the literature citing changes in renal excretion of drugs or renal clearance of drugs in the ICU. And you can see the percent of patients there is on the left side there. So the first column the first category in each column is the patients who have a decreased half-life of a drug or an increased clearance of a drug. The second column in red is no change in the half-life or no change in the clearance of the drug. So this is where we would expect to see the kidneys operating as they would in a normal patient population, maybe an ambulatory or hospitalized patient population. The last is where the drugs would have an increased half-life or we would see a decreased clearance of these drugs. And so again, reiterating the concept that our ICU patient population changes rapidly, we can see patients who fall into all of these categories. We'll take some time and focus on, in just a minute, the patients in the first column, the lighter blue, where we see a decreased half-life or an increased clearance. And despite what the slide here shows you in terms of our trauma patients, we oftentimes see this as a common characteristic of our trauma patients. We know it's definitely, as the slide indicates, a common characteristic of burn patients, probably less so in medical patients. But this is something I think that is underappreciated in the care of ICU patients. And in fact, when you look at the pharmaceutical industry, they oftentimes don't study the disposition of drugs in patients who have this augmented renal clearance. And the patients who have a normal half-life or normal clearance, we'll treat them basically as normal patients. And then obviously the converse, where we expect to see someone who's developed acute kidney insufficiency or possibly acute kidney insufficiency on top of some chronic kidney insufficiency or chronic kidney disease or end-stage disease. The key that I like to show with this slide is that on day one, you may have a patient who falls into the first category where they have an increased clearance. On day three, you may find that they are in the decreased clearance. And so something that I like to emphasize here is that any patient could be any of these at any time in the ICU, depending on what's going on with them clinically. And you heard me use the term just a second ago, augmented renal clearance. So this is something that's been newly identified, or at least newly discussed in literature. And the definition varies. You may see it as an increase in renal elimination of drugs characterized as a creatinine clearance that's estimated at greater than 10% of normal. You may also see it reported in the literature as a creatinine clearance of greater than 150 in women or greater than 160 in men. The duration that's been reported in the literature is variable, but generally what you expect to see is that patients will demonstrate augmented renal clearance for 4 to 5 days. I can tell you that I've seen patients who've demonstrated this much longer, but generally you see this for about 4 to 5 days, and you may see it up to 7 days. This is really important because oftentimes we say when starting a medication that we would be monitoring, we know is renally eliminated, renally excreted, we would say, oh, just start them on the dose they were on before because that was the right dose back then, that got us therapeutic, and so therefore we should be good with that dose now. And that's not always the case, and I've seen anecdotally this happen multiple times where someone started a patient on a previous dose, and when they had previously been dosing them, they most likely demonstrated augmented renal clearance. And so the result of this was that the patient ultimately ended up being overdosed the second time that they received the medication because their kidney function had returned closer towards normal, closer to normal than what it was previously. And so it helps if we figure out what kinds of patients would we expect to see develop augmented renal clearance. And you can see here in the study by Udi, the conditions that were independently associated with the development of augmented renal clearance were trauma. So as I mentioned to you before, my practice and what I tend to see in our patients is augmented renal clearance. Age, specifically those younger than 50 years. And then a modified sequential organ failure score of less than 4. And so what this is demonstrating is that the patient needs to be sick, probably have some degree of inflammation occurring, either demonstrating SIRS criteria, possibly some sepsis criteria, but they can't be so far into this that they've developed significant organ failure based on the modified sequential organ failure score, because at that point then what you'll begin to incorporate is those patients who've developed acute kidney insufficiency, and those patients will probably have either normal or lower than normal kidney function. So low level of organ failure, young and trauma patients have been demonstrated in this study to be the ones that we would expect to see to develop augmented renal clearance. They were independently associated with that. I think it's important to note some other conditions where we've seen augmented renal clearance, but maybe haven't systematically studied it to identify these characteristics or these patients as independently associated with development of augmented renal clearance. I think patients who have burns surely have some degree at some point of augmented renal clearance. Those that have experienced surgery, and then those that are in the hyperdynamic state of sepsis, where we see this increased cardiac output, increased perfusion of the kidneys. And if you look at the conditions here, trauma probably incorporates in surgery, and the patients who are younger are more likely to respond to sepsis, early sepsis with hyperdynamic state. And so it kind of goes along with this, but I do believe that these are other important categories that you should be aware of in the ICU who may have augmented renal clearance. Let me just jump back to this. We estimate augmented renal clearance using the Cockcroft-Gault, but oftentimes, and again, this is an anecdotal story here. We collect 24-hour urine collections in our trauma ICU patients to measure their nitrogen balance for the nutrition support service. And what I've seen is that the measured um, kidney function, the measured creatinine clearance is oftentimes much higher in our trauma patients than the estimated if you were to use Cockcroft Galt. And so I think we will begin to see that there are patients who have increased clearance above what we are estimating using our equations because they are somewhat limited. So the flip side of the augmented renal clearance is acute kidney injury. The incidence has been reported to be 1% all the way up to 25% of all ICU patients. So pretty broad ranging incidence. And I think it varies depending on how sick the patients are, what types of patients you're seeing in the ICU. One study also noted that AKI was involved in up to 78% of ICU admissions. And so 78% of ICU admissions have some degree of involvement with AKI. That seems a little bit high, but that has been reported in the literature. Also, developing acute kidney injury, we see mortality rates that range from 15 to 60%. So the KDIGO guidelines have provided definitions for us of acute kidney injury, and you can see increases in the serum creatinine by 0.3 milligrams per deciliter within 48 hours, increase in serum creatinine to 1.5 times the baseline within 7 days, or urine volume of less than 0.5 mils per kilo per hour for 6 hours. And so these guidelines are similar in as far as their staging goes as the other two recommendations for staging of AKI that we see, the rifle criteria and the akin criteria. And so I generally, when I'm teaching about this, I generally teach all three and describe the slight differences in between them. But I think as long as you're looking for these, you're going to be catching the patients who are in acute kidney injury. What about pharmacokinetics in these patients? Well, we expect to see renal excretion of drugs to be decreased, renal metabolism of drugs to be decreased. Estimation of renal excretion, there's numerous equations, especially when we're looking specifically at patients with changing renal functions. We may be seeing use of GELF and GELF, but there's tons of equations out there. We'll talk about which ones you might use in just a minute. Also, we have to take into consideration continuous renal replacement therapy in the reports noting increased, normal, or decreased excretion of drugs depending on all sorts of factors such as the filters used, the rates used, what the medications are. And so it can be fairly tricky in determining what effect you might expect to see in patients with AKI and CRRT. Matsky was the lead author on an update to the KDIGO recommendations where they were talking about what types of things should we be doing to estimate kidney function, specifically as it relates to what we're going to do with our drug dosing. And you can see the updated recommendations they gave that you can predict or estimate the patient's kidney function using any of these equations listed here, as long as you are consistent with what you're using to estimate their kidney function. You'll receive a lecture, I think it's a live lecture, on AKI and specifically in CRT, so I'll defer to your speaker there for what specifically you should do when you're trying to figure out dosing of a drug in CRT. But Matsky also gave us some guidance in this, and he provided this equation here that basically shows what we would expect the dose to be in someone on CRT. But you have to collect these variables, and so it's going to take a diligent pharmacist to go through and ensure that they've collected all the appropriate variables. What you see here is the dose that we would use in CRT would be equal to the normal dose multiplied times the non-renal clearance of the drug plus the effluent rate of that CRT and the Seving coefficient of the CRT, and that's all divided by the normal clearance of the drug. And that would give us an estimation for the dose we would want to use in CRT. Okay, so now we've gone through absorption, volume of distribution, metabolism, and excretion. Let's briefly touch on pharmacodynamics, and then we'll round out with therapeutic drug monitoring. So question number 5. The pharmacodynamic parameter, AUC to MIC, best describes the efficacy of which of the following antibiotics? Gentamicin, cefepime, ciprofloxacin, or linezolid. So I'll give you a moment to think about that. Okay, so ciprofloxacin or fluoroquinolone, the pharmacodynamic parameter that we use to characterize its efficacy is AUC to MIC. Let's talk a little bit about pharmacodynamics. Pharmacodynamics is the biochemical and physiologic effects, mechanism of action specifically. Oftentimes, this is noted by physically identifiable effect of that drug. And so, for example, if we were to look at patients receiving an opioid pain reliever, we would look to see what type of response do they have in terms of their pain score. So are they achieving pain relief or are they still in pain? And that's not the pharmacokinetics because that could be independent of the concentration of that opioid in their blood. But it is pharmacodynamics in terms of what specific physiologic effect are we seeing from these opioids. Benzodiazepines are another one where we look at the degree of sedation. And we do this pharmacodynamic monitoring in the ICU pretty frequently. We just don't realize that we're doing it. We also have some non-observable pharmacodynamics. So stuff for the antibiotics, we can see these have been characterized as Cmax to Cmin, Cmax to MIC, time above the MIC, and AUC to MIC. Proton pump inhibitors, the pharmacodynamics have been described based on gastric pH, but none of these are things that we'll actually see. So in the clinical care of patients, we won't know what the concentration max is to the MIC of the bacteria. We'll have some estimations or some guesstimates, but we won't actually know that. Nor will we know the pH in a patient who's on a gastric pH of the patient who's on a proton pump inhibitor. So what types of changes would we be concerned about in our patients in the ICU in terms of pharmacodynamic alterations? Well, we can see decreased response, increased response, and variable response. And what you see here are we've noted in the medical literature that low molecular weight heparins in edematous patients, we found lower AUCs for anti-10A activity. Opiates and sedatives, this is anecdotal, but we've seen larger requirements than what you might expect. I can still remember the first time that I saw patients receiving hydromorphone, their response was not did not correlate well with the morphine equivalents that I was expecting it to. Antibiotics, you're going to find aggressive dosing is often required to achieve these pharmacodynamic goals. And there are a plethora of data out there looking at Monte Carlo simulation in our ICU patient population and ultimately recommending very aggressive dosing in these patients. You may see an increased response, hepatically metabolized drugs and liver failure, renally excreted drugs and AKI. The response is going to be proportional to the concentration of that drug, but we'll see an increased response. Variable responses, it's interesting. Some studies have found heparin infusions that ICU patients have an increased response, basically a shorter time to therapeutic APTTs, or a decreased response, less than 50% of the therapeutic APTTs at 24 hours. So it's really variable based on what population you're looking at, and neither of those studies were able to give us any characteristics of why we saw differences in response in those patients. So I'm going to discuss some important pharmacodynamic principles of antibiotics. It's important to note that these are not specifically related to the critically ill patients. We would apply these principles to any patients. But time above the MIC, and so you can see here we have a concentration versus time curve. When we're talking about time above the MIC, we're specifically looking at the time from the point at which the drug concentration comes above the MIC. The bacterial MIC is the dotted line there. We want this to be greater than 50% of the dosing interval. You can see with beta-lactam antibiotics, it's ideal to be 100%. And so we'll find clinicians using extended interval dosing. So we're giving extended infusions up to 4 hours of these beta-lactams to try and improve that, or continuous infusion of these drugs. The range is around 50 to 100%. Carbapenems, clindamycin, linezolid, all of these are important. Cmax to Cmin, again, we have our curve, we have the bacterial MIC, the peak concentration or Cmax, and what we're looking for is a Cmax to MIC ratio of 8 to 10, and the traditional one that we see here are aminoglycosides. For extended interval dosing of aminoglycosides is a way that we maximize this. The last is AUC to MIC. And so we have, our concentration time curve, and we're looking at the area under the curve as it relates to the bacterial MIC. For vancomycin, the current guidelines recommend that we use an AUC to MIC of greater than or equal to 400. For fluoroquinolones, we've seen reports of greater than 125 for gram negatives, greater than 35 for gram positives of strep. And let me just jump back real quick to all three of these. What I've given you is, on the last bullet of each slide, is the likelihood that we might see changes in our ICU population that could affect this. So increased elimination of drugs, either metabolism or excretion, that would decrease the time above the MIC. Changes in the volume of distribution can significantly impact the Cmax to MIC ratio. And increased elimination has the potential to decrease the AUC to MIC. So we've gone through absorption, volume of distribution, metabolism, excretion, pharmacodynamics, and I'll just briefly touch on therapeutic drug monitoring. The definition here is measurement of a drug concentration. We are trying to maximize the efficacy, minimize the toxicity. And so as a result, therapeutic drug monitoring is not extremely common in our patients. If you look at the vancomycin guidelines, we may be checking a trough concentration, but we aren't going to be doing any pharmacokinetic alterations here. We're looking at specifically timing of a concentration, and it's dependent upon the efficacy versus toxicity. So we're looking about aminoglycosides. The trough would be a marker of toxicity. Elevated trough, we're worried about the development of AKI. Vancomycin troughs we measure, and for efficacy, sort of. There have been no studies that have effectively correlated vancomycin troughs to efficacy or treatment of specific infectious diseases. And then we'll look at patient-specific pharmacokinetic calculations. And I always use my example here from my patients in the ICU. The standard dose of vancomycin being 15 to 20 milligrams per kilo for our patients. And what we see here is that oftentimes this results in a 1 to 1.5 gram dose of vancomycin given every 12 to possibly 8 hours. I regularly have patients in the ICU who are on 2 grams of vancomycin every 6 hours. And very recently, one of my colleagues required dosing of 2 grams every 4 hours in one of the trauma patients to achieve a trough of 15. And so you may see patient-specific calculations being done. There was no way we could have gotten to that dosing without measuring the peak and the trough and actually calculating out the patient's clearance. We can incorporate drug nomograms into the treatment of our patients. A nomogram is basically the diagram of a relationship between 3 or more variables. And I've given you the example here of an extended interval dosing of aminoglycosides. So we determine one unknown variable based on 2 known or possibly more known variables. And so the known variables would be what concentration we obtained and how long after the start of the infusion to the drug level. And then whatever that drug level was based on the time that we obtained it, then we could look and see what type of dosing interval we would use. So we could establish either once daily, once every 36 hours, or once every 48 hours dosing for aminoglycosides. And so we'll oftentimes incorporate this in. The key here is that we do have the variable points because our critically ill patients may not conform to the norms here. And so having these two known points, like a concentration and following the time from the start of the infusion, we may be finding our patients falling um, into these categories, or it may be that we see with some patients like this with augmented renal clearance where they don't quite fit this nomogram. So it's important to be sure that we're using these with the understanding of patient-specific factors that might apply in the ICU. And with that, I'll go ahead and close out. Thank you so much for your time. I hope you enjoyed the presentation.